Hello and welcome to the Journal of the American Society of Echocardiography podcast. Editor-in-Chief Dr. Michael Picard, Managing Editor Deborah Meyer, presented by myself, Dr. Amar Jory. Today's article appears in the December 2020 issue of the journal and is entitled Identification of Subclinical Myocardial Dysfunction and Association with Survival After Transcatheter Mitral Valve Repair by Dr. Mihu Fukui and colleagues. Mitral regurgitation is one of the most common valve diseases in developed countries, and its prevalence is expected to increase with an aging population. Severe MR is associated with increased morbidity and mortality without mitral valve intervention. Transcatheter mitral valve repair with edge-to-edge mitral valve clip is an effective treatment of patients with severe symptomatic mitral regurgitation who have high or prohibitive surgical risk. However, there is heterogeneity in the clinical response to transcatheter edge-to-edge mitral valve clip procedure despite achieving adequate MR reduction with a reported 25% mortality at 1 year in the ACC-AHA Transcatheter Valve Therapy Registry. Current guidelines emphasize evaluation of symptoms and assessment of LV ejection fraction and LV end systolic diameter as triggers for mitral valve intervention. However, subclinical myocardial dysfunction assessed by global longitudinal strain may be present in patients with severe MR despite normal EF and LV end systolic diameter and may be associated with poor prognosis. Speckle tracking echocardiography-derived global longitudinal strain has been shown to be a non-invasive imaging technique that can detect the subclinical myocardial dysfunction beyond ejection fraction. While preoperative global longitudinal strain was shown to be associated with poor outcomes in patients with severe degenerative mitral regurgitation who underwent surgical mitral valve replacement or repair, its clinical utility is unknown in patients treated with transcatheter mitral valve repair with edge-to-edge mitral valve clip, which is currently approved for the treatment of patients with degenerative mitral regurgitation and high surgical risk. Growing worldwide experience with transcatheter mitral valve repair will continue the drive for improving outcomes and identification of predictors beyond standard clinical parameters. Therefore, we sought to evaluate the association of baseline global longitudinal strain with 1 year all-cause mortality after transcatheter mitral valve repair with edge-to-edge mitral valve clip in patients with severe MR, beyond EF and other traditional clinical risk factors. The methods and results section of this paper have been abbreviated for ease of listening for the purposes of this audio. Methods. We analyzed 155 patients who underwent transcatheter edge-to-edge mitral valve clip implantation with a mean age of 83 years. 48% were women, and the mean LV ejection fraction was 56%. The Society of Thoracic Surgeons predicted risk of mortality score for repair was 6.62%. Baseline LV global longitudinal strain was obtained by two-dimensional speckle tracking echocardiography, averaging 18 segments from 3 apical views. Receiver operating characteristic analyses were used to assess the global longitudinal strain cut point associated with all-cause mortality. Multivariable models with Cox regression tested its relationship after adjustment for baseline comorbidities. Strain analysis. Strain analysis was performed offline using commercially available software. The 18-segment model, 6 segments per view, was used for global longitudinal strain analysis by averaging the 3 apical long-axis views, the 2, 3, and 4 chambers. For patients in atrial fibrillation, we used a single index beat method, which has been validated for global longitudinal strain evaluation in these patients. In short, it establishes that if the RR interval ratio of the two preceding beats equals 1, then the third beat can be used as the representation of average LV contractility. Therefore, in these patients, we chose the index cardiac cycle just after two cardiac cycles of similar length and or with a maximal RR interval difference of less than 60 milliseconds. All global longitudinal strain measurements were conducted by Dr. Miho Fukui and digitally stored and later analyzed completely blinded for all clinical and survival data. Results. During a mean follow-up of 316 days, all-cause deaths occurred in 30 patients at a median of 156 days after transcatheter mitral valve repair. The area under the curve of preoperative global longitudinal strain associated with the outcome was 0.60, with a cutoff point of minus 14.5%. Baseline global longitudinal strain greater than minus 14.5% was associated with 1-year mortality before and after adjustment for baseline characteristics. After accounting for baseline characteristics, patients with global longitudinal strain greater than minus 14.5% had worse 1-year mortality than those with a global longitudinal strain less than or equal to minus 14.5%. In nested Cox proportional hazards models, the addition of baseline global longitudinal strain to the Society of Thoracic Surgeons predicted risk of mortality score, LV ejection fraction, and the etiology of MR significantly increased the model x-squared value. Discussion. In this study, we evaluated the association of baseline global longitudinal strain with 1-year all-cause mortality using a cohort of patients with symptomatic severe mitral regurgitation treated with transcatheter edge-to-edge mitral valve clip. Our study has two key findings. First, patients with global longitudinal strain greater than minus 14.5% had higher all-cause mortality post-transcatheter repair than those with a global longitudinal strain less than or equal to minus 14.5%. Second, baseline global longitudinal strain was independently associated with 1-year all-cause mortality and exhibited incremental value for the risk of all-cause death over other clinical and echo characteristics, including left ventricular ejection fraction. Our study results may have implications for optimal patient selection and risk stratification. Role of global longitudinal strain evaluation in patients with MR undergoing surgical intervention. Although the current indications for mitral valve intervention in severe mitral regurgitation patients mainly rely on the presence of symptoms, reduction of EF, and or dilatation of end systolic diameter, these parameters might be insufficient. Mentias et al., using a cohort of 733 asymptomatic patients with moderate to severe mitral regurgitation and preserved EF, showed that a preoperative global longitudinal strain less than minus 21.7% was independently associated with mortality with median follow-up of 8.3 years. Left ventricular ejection fraction and end systolic diameter can remain preserved until the end stage of MR due to LV hyperkinesis in compensation for volume overload of the left ventricle. Speckle tracking echocardiography-derived global longitudinal strain can detect subclinical myocardial dysfunction and provides incremental prognostic value in a variety of clinical settings beyond EF. Left ventricular ejection fraction describes a relative change of stroke volume, whereas global longitudinal strain describes the longitudinal deformation and shortening of the myocardium through the cardiac cycle. For patients undergoing surgical intervention, Kim et al., in a study of 506 patients with severe degenerative mitral regurgitation who underwent surgical repair or replacement, showed that preoperative global longitudinal strain was associated with all-cause mortality and provided incremental prognostic information beyond conventional risk factors, including EF. Witkowski et al. Reported that baseline global longitudinal strain greater than minus 19.9% predicted 1 year postoperative EF less than 50% in 233 patients with moderate to severe mitral regurgitation who underwent surgical mitral repair. Of note, patients currently undergoing transcatheter mitral valve repair are older and have higher prevalence of comorbidities and clinical risk than those treated with surgical mitral valve intervention. Therefore, these previous results do not necessarily apply to the patients undergoing transcatheter mitral valve repair. Prognostic value of global longitudinal strain in transcatheter mitral valve repair with edge-to-edge mitral valve clip. Our study is first to demonstrate that mortality risk associated with impaired global longitudinal strain appears to be independent of and incremental to other clinical and echo characteristics, especially above the STS-PROM score, EF, and etiology of MR in a cohort of patients treated with transcatheter mitral valve repair with the edge-to-edge mitral valve clip. Little data are available on the role of preoperative global longitudinal strain evaluation for outcomes in patients treated with transcatheter repair. Citro et al., using a smaller cohort of 41 symptomatic patients with moderate to severe functional mitral regurgitation treated with transcatheter repair, showed that baseline longitudinal strain greater than or equal to minus 9.25% was associated with lack of reverse LV remodeling, defined as greater than 10% reduction in LV and systolic volumes at 6 months follow-up. Given the small number of events, they were not able to establish an independent association with clinical outcomes. We build on their findings by showing, in a cohort of symptomatic severe MR patients treated with transcatheter repair, that baseline global longitudinal strain was capable of providing independent and incremental risk stratification. The differences in global longitudinal strain cutoff values between their study and ours could well be due to the differences in the study populations, etiology of MR, and chosen endpoints. While in our studied population, patients had predominantly degenerative mitral regurgitation with preserved EF, Citro et al. Included only patients with secondary MR with a mean EF of 34%. Further prospective studies are needed to define the role of baseline global longitudinal strain assessment in the risk stratification of patients being considered for transcatheter repair. Global longitudinal strain has emerged as an important tool to quantify the degree of subclinical myocardial dysfunction seen in patients with severe MR, but not captured by traditional echo parameters. Patients currently undergoing transcatheter mitral repair have higher prevalence of comorbidities and clinical risk than those treated with surgical mitral valve intervention. Although identification of abnormal global longitudinal strain should not preclude performance of transcatheter edge-to-edge mitral valve clip procedure, its baseline assessment provides the opportunity to identify patients who might benefit from a closer follow-up after the intervention. Limitations. First, this was a single-center retrospective study evaluating predominantly primary degenerative mitral regurgitation patients. We acknowledge that the number of patients with secondary functional mitral regurgitation is too small to be evaluated independently, and that further larger studies, including these patients, are needed to confirm and expand our findings. The discriminatory capability of global longitudinal strain in isolation is modest in this cohort with mixed primary and secondary mitral regurgitation, and other comorbidities could be also associated with the outcomes in these patients. However, we showed incremental value of reduced global longitudinal strain above functional mitral regurgitation, STS-PROM score, and frailty on mortality using multivariable Cox regression analysis and nested models. Second, cause of death was not available for all patients, limiting the causal relationship analysis. Third, although we have only analyzed at this time the prognostic role of baseline global longitudinal strain, it is possible that interval global longitudinal strain changes might be equally associated with the outcomes. However, the follow-up post-transcatheter mitral valve repair data on global longitudinal strain changes and reverse remodeling are not currently available at the time of this analysis. Fourth, longer follow-up was not available at the time of this analysis, limiting the association of baseline global longitudinal strain with long-term outcomes. Fifth, other important parameters such as brain natriuretic peptides levels and 6-minute walk distance were not consistently assessed in this cohort but are potentially associated with their outcomes. Finally, we acknowledge that we did not perform an external validation of the proposed cutoff values of global longitudinal strain of minus 14.5%. Our findings would require validation in other groups before the routine implementation of this new parameter. Conclusion. In patients with symptomatic severe mitral regurgitation treated with transcatheter mitral valve repair with edge-to-edge mitral valve clip, pre-procedure global longitudinal strain greater than minus 14.5% was independently associated with 1-year mortality. Assessment of baseline global longitudinal strain provides independent and incremental prognostic value above multiple clinical and echo characteristics and improves risk stratification in these patients. I would like to repeat the highlights of this study. First, mortality in high-risk severe mitral regurgitation patients treated with Mitra Clip was associated with baseline global longitudinal strain values. Secondly, reduced global longitudinal strain at baseline was associated with 1-year all-cause mortality. Finally, results may improve current risk stratification in patients considered for Mitra Clip therapy. If you found the previous article on global longitudinal strain and mitral clip procedures interesting, then you may also find the following interventional echocardiography communication of interest. This short communication also appears in the December 2020 issue of the journal and is entitled Interventional Echocardiography, a new specialty interest group for the American Society of Echocardiography, by Dr. Rebecca Hahn, David Rubinson, Dr. Burkhard Mackinson, Dr. Mohammed Sarek, Dr. Stephen Little, Dr. Feroz Mahmood, Dr. Sheila Paikol, and Dr. Nishath Kader. Structural heart disease interventions are at the cutting edge of innovation for the treatment of valvular and other structural cardiac diseases. Since the initial partner trial began in 2007, there has been a slow but steady swell of echocardiographers drawn to this new field. The universal recognition of the central role of the imager on the heart team has resulted in the creation of a new subspecialty within cardiology and anesthesiology, the structural heart disease interventional echocardiographer. Interventional echocardiographers are crucial to the technical success of many complex structural heart disease procedures because they possess specialized knowledge sets as well as advanced image acquisition and interpretive skills. The recent 2019 American Association for Thoracic Surgery, ACC, ASE, and Society for Cardiovascular Angiography and Interventions, and Society of Thoracic Surgeons Expert Consensus Systems of Care document for valvular heart disease, and the 2019 ACC-AHA training statement on echo identify the need for an echocardiographer with expertise in valve disease and transcatheter and surgical interventions to provide imaging guidance for transcatheter and intraoperative procedures. Every journal of the American Society of Echocardiography blue pages written on this expanding new subspecialty has emphasized the need for appropriate education and training. Defining the minimum standards for competency within the field of structural heart disease is in constant evolution as the field continues on an upward trajectory with both new devices and advanced imaging platforms. In answer to this call to arms for our society, a new specialty interest group, Interventional Echocardiography, has been formed to support and expand the physician and sonographer members participating in these complex procedures. As structural heart disease interventions continue to grow, even those sonographers and echocardiographers who may not perform intraprocedural imaging will need to understand the baseline and follow-up imaging requirements for these exciting new interventions. Thus, the Interventional Echocardiography Special Interest Group hopes to 1. Provide a community within ASC for open discussion and cross-training about the imaging involved in these complex procedures. 2. Promote the ASC guidelines and consensus documents related to structural heart imaging. 3. Develop and disseminate educational materials for these professionals. And 4. Open a dialogue with other imaging societies, engineers, clinicians, and the industry to promote the growth of this new imaging subspecialty. The Interventional Echocardiography Special Interest Group is open to all ASC members, and identifying yourself as interested in this special interest group will help the group accomplish these goals. The Interventional Echocardiography Special Interest Group has already begun scheduling educational programs. The first was an ASC Twitter Journal Club on October 27th, focusing on the assessment of aortic stenosis in the setting of irregular rhythms. In addition, a live webinar case series is planned beginning in December of 2020, in which structural heart disease cases will be co-presented by imagers and interventionalists to a panel of experts with an open question and answer session for attendees. Many more educational programs are being planned for 2021. It is imperative for those that are involved in this field to identify themselves with this Interventional Echo Special Interest Group, since this will provide us with a stronger stance when presenting the numerous challenges facing this field to the leadership of ASE. These include appropriate compensation, reducing radiation exposure, and education, to name a few. These challenges will attract attention only with a collective voice, as will be reflected in the number of members in the Interventional Echo Special Interest Group. I hope you enjoyed the article summary on the Mitra Clip association with global longitudinal strain values, as well as the short communication from the Interventional Echo Special Interest Group. Both of these articles are available online and in the current issue of the Journal of the American Society of Echocardiography. Thank you once again for joining me in this weekly JASE podcast series. I hope to provide the final series next week to round out this year. Thank you.